Hello everyone. I'll be talking about antipsychotics in treatment-resistant anxiety disorders. These are medications that we prescribe a lot for different indications, but what are the pros and what are cons? We prescribe them very frequently in anxiety disorders, the antipsychotics. What do we do in our own anxiety disorder clinic? I first wanted to investigate that, but when we have this printout, 50 of 270 patients we have been put on typical and atypical antipsychotics, with obsessive-compulsive disorders leading the way. Now, to review the literature again, what are the pros and what are the cons? We will be reviewing it again. Now, yes, we use them a lot, atypical antipsychotics, but what is their effect size? What is the mechanism that causes the resistance? We have limited information on that. Findings are complicated. In fact, when we talk about anxiety disorders, we are talking about 4 or 5 different disorders. They all have different etiopathogenesis, and we're talking about different medications. Then there are different regulations maybe playing a role in different diseases. Which mechanisms may play a role in increasing efficacy? Pharmacokinetic or pharmacodynamic mechanisms, probably. The pharmacokinetic mechanism, what kind of an effect can it yield? In fact, many of them are metabolized over cytochrome enzymes, and when they're used with SSRI, this is an important pathway for them. But in strengthening the effect of antidepressants or the emergence of anxiolytic effect, this pathway does not seem very likely. Rich receptor profiles of antipsychotics is a pharmacodynamic and pharmacokinetic mechanism. For instance, their effect on dopamine receptor, their effects on serotonergic receptors and other receptors. I'll try to address all of them today. In atypical antipsychotics, when we use them for different indications, we usually prescribe them at lower dosages. Standard antipsychotic dosages, much lower than those. And the D2, D3 receptor antagonism is one of the basic effect mechanisms, but at these dosages, D2 receptor antagonism is affected in a lower scale. Brain studies have shown that when used at lower dosages, D2 receptors are involved only 50% of the time. So, is a low D2 receptor invasion different then? And not only D2, of course, D3 and other dopaminergic receptors are blocked by antipsychotics, atypicals that is, so can they have an important mechanism to play? Data is limited, but we should be keeping those in mind. Excessive low D2 receptor involvement seems to be enough to reinforce antidepressant effect. Partial D2 agonism, weak D2 antagonism. Can this be an equivalent effect? Again, D3, D4 receptor affinity, can it be playing a role, or as a result of the interaction of all of these receptors, do we have a common impact? Atypical antipsychotics, of course, another important receptor is the serotonin, particularly 5-HT2A. This is a strong impact, and when used at lower dosages, they have a high receptor involvement. When we look at preclinical studies, 5-HT2 antagonism increases antidepressant effect of fluoxetinin. It says of atypical antipsychotics, 5-HT2A antagonism seems to be an important impact. Partial 5-HT1 receptor effect reinforces the AD effect, and in treatment-resistant cases, it seems to be an important pathway in resistance. The other serotonin receptors, 5-HT2A receptors, we have limited information on them, but especially the regulation of sleep, poor sleep, it is an important receptor profile, it is said. 5-HT6, 5-HT7, it's as if not compulsive for strengthening the antidepressant effect, but can it play a role? Can it contribute? The data makes us think so. Another 5-HT2B receptors, they may play a role. With their stimulation, serotonin levels accelerate. They may stimulate the trigeminal nerve and cause headaches, and in somatic side patients, adding antipsychotics may be equivalent to the pharmacokinetic mechanism. Other receptors like histamine receptors, the antagonistic effect, especially quetiapine, olanzapine, have strong antihistaminic effects, and they regulate sleep disorders. However, their antihistaminic effects, they do not contribute to strengthening the effects of antidepressants. These have to do with side effects mostly, it is said. We don't have strict data. Muscarinic has anticholinergic side effects. A single receptor is difficult to introduce because there's such a rich receptor profile for these medications. So talking about a common effect, the common interaction on all receptor levels in the prefrontal cortex, there are changes in neurotransmitters, and does it reinforce antidepressant effect? Maybe this is the more important common pathway. Another important pathway is neurogenesis. Antidepressants stimulate the neurogenesis. Antipsychotics do so too. Again, 5-HT1 receptor mechanism. Over this, the neurogenesis is stimulated. Then another pathway that should not be forgotten is the stimulation of the neurogenesis. Okay, after this general introduction, let's now look at the diseases one by one. What's our clinical use? What are the findings? I want to discuss that. In obsessive-compulsive disorder, it's one of the most difficult to treat. It ranks high with regard to loss of competence, so it has to do with antipsychotics and other medications. So it's a combination disease group. What is the algorithm here? In all algorithms are in the treatment guide of Turkish Psychiatry Association prepared in 2002, and Bandello's treatment guideline published in 2008. I compared those two. Our Turkish Psychiatry Association's treatment guideline says that antipsychotics are for these people who do not respond to SSRIs. These are reinforcement treatments. There are several meta-analyses, but I will compare the results of two analyses. Bloch's 2006 meta-analysis. Which antipsychotic is more effective in OCD? Many antipsychotics are added for reinforcement purposes, but what does research show? 9 randomized controlled studies on 278 patients. They have assessed the results together. 1 haloperidol trial, 3 risperidone trials, 2 olanzapine, and 3 quetiapine trials. So all data have been assessed all together, and they say that in general, atypical antipsychotics, they reinforce the effect in OCD, but about risperidone and haloperidol, findings relating to those, risperidone and haloperidol findings seem to be stronger more important. It's as if the others are close to being ineffective, but atypicals do have an effect, of course, when we assess generally. So when to add atypicals for treatment, if it's beneficial, let's use them together from the outset. But the findings do not support this. At least 12 weeks of SSRI treatment, non-response has to be there. Atypical antipsychotic, when it is added, it yields better results. So you have to be patient. SSRI treatment, you have to show non-response to SSRI treatment. In current treatment guidelines, 2 different SSRIs or 3 SSRIs, some say, but at least for a period of 12 weeks we have to wait. Okay, so for how long shall we wait for the response to emerge? 3 days, 1 month? Again, Bloch and his friends, when we look at the meta-analysis, they say using antipsychotics for more than 4 weeks does not contribute with regard to effect, but another meta-analysis shows that this time frame can be extended until 8 weeks, and this is also our clinical opinion. In OCD is a difficult disease group, so we should keep this time long if we can. Most of the time, our knowledge is that response to antipsychotics will increase if there are tics present. This meta-analysis seems to be partially supporting this. Yes, in the presence of tics, the presence of antipsychotics is more, but how strong a finding is this? It's not close to being insignificant, so we should be a bit careful maybe. Okay, so how shall we conclude? How shall we apply this to the clinic? The takeaway message. I guess we should not be forgetting that we should be a bit patient for adding antipsychotics. At least 12-week tolerable highest dose SSRI treatment should be done, but there should be no response. Then we can foresee positive response to the addition of antipsychotics. Will every patient respond? 1/3 of resistant cases response to the addition of AP. Findings about haloperidol and risperidone seem to be stronger, but when we look at the guideline of 2008, it says that all AP are B category evidence value. Quetiapine and olanzapine related findings are still suspicious, it seems, even though lower dosages have been recommended. Lower dosages than usual. Scapinatis and his friends saw that together with higher dosages, response probability may go higher. So not 4 weeks, maybe 8 weeks we should wait. And higher dosages, standard dosages, should be targeted in the case of insufficient response. Aripiprazole-related word-of-mouth positive experiences are heard, but there are limited cases. Therefore, yes, it is promising because of its partial dopamine and 5-HT1A agonist impact. It is useful, but limited. This is all I wanted to say about OCD. Of course, there are different anxiety disorders I have to address separately. Now I'm going to be talking about generalized anxiety disorders. What is recommended? I want to touch upon those. Again, when we look at the treatment guidelines, among treatment standards, APs are not present, but again, Bandelow's 2008 treatment guidelines says that particularly quetiapine is the rising star. It is being elevated, it is elevating to the A category. And again, Bandelow's guideline says that 50 to 300 milligrams is superior to quetiapine, as effective as paroxetine, and its effect starts as of week 1. But still, when we look at the trials, they're not that wonderful, it seems. So therefore, we have to be cautious in our approach. Again, olanzapine B category, and it's used with SSRIs, and olanzapine by itself are effective, especially in treatment-resistant cases. Again, Risperidone is B category, and together with antidepressant at lower dosages, it is more superior to the placebo. In spite of that, another trial published in 2008 said that it really is not much different from the placebo. So we have to approach cautiously. These are borderline findings. So when prescribing or when you're adding on, the criteria have to be reviewed. Post-trauma stress disorder, we have challenges in treatment, but we look at standard guidelines. Atypicals or typicals are not found, but in clinical practice we do add them on. Randomized controlled studies are limited, but in spite of that, there are important findings supporting efficacy. Kosaric and Kovarik published something about PTCD treatment. So you see the trials here, and when you look at the outcomes section, in many trials they have found positive results, improvement, healing effects on different aspects. I will talk about the meta-analysis now, published in 2008. 7 randomized control studies. It's the data from these that are assessed altogether. 2 olanzapine trials and 5 risperidone trials. Data assessed. So what did they find? Hay et al. They say that when we look at it, atypical APs, when they're added to treatment, it seems like effective in post-trauma stress disorder. But my stronger finding is that 2 trials are on the borderline of inefficacy, and the outcomes of other trials show that. This is the outcome of the meta-analysis, but we have to be cautious again. Risperidone included in this meta-analysis. What is their CAPS subscale scores? Remembering aversion and overexcitation, and it seems that risperidone has more important effects on remembering again and again, and this is interpreted as follows. This remembering again and again signs, is it like a thought disorder, or can it be equal to delusions? Sandra. Post-trauma stress disorder. If we're going to be adding atypicals, we have to be cautious that for specific symptoms or sleep, but in the presence of psychotic signs. And in 20% of cases there may be psychotic signs. There should be psychotic and behavioral signs in cases which don't respond to standard treatment. Especially, it may have an impact on remembering again and again. When you look at the type of trauma, SSRIs are not effective for situations like war or terror. And in cases where there are also psychotic signs, antipsychotic efficacy may be a predictor. If we could wrap it up, please, in panic disorder findings, when we look at the treatment guideline, no standard treatment here, only in concomitant comorbidities, bipolar disorder, mood disorder, isolated panic disorder, in resistant cases, monotherapy or combination, C1 category in below guideline. If we want to wrap this up now, it says if OCD and post-trauma stress disorder seems to be stronger. It should be several patients would not respond to standard treatment when there's comorbidity like psychosis, mood disorder. It may be an option for reinforcing treatment. However, efficacy should be monitored, and if there is not enough effect, medication should be discontinued, because the most important thing, complication in combination, is to continue an ineffective drug for a long time. we have to score the effect, and we have to follow the side effects. Data to date show that there's not a different side effect profile in anxiety disorders, but metabolic side effects, weight gain with regard to those, we should be monitoring the patient.